2 minutes, ma'am. I'll just.
Yeah.
Is it coming in slideshow, ma'am, now?
Let's just start at screen sharing. Just a sec. It's not visible.
Deepti, it's not in slideshow mode.
Okay, ma'am. Okay, I'll just try once again,
We are
ma'am.
seeing
Ma'am, it's coming in slideshow here for me. I'll
we are
just try
also
one.
the screen, but it is not in slideshow.
Oh, okay, one second. I'll just try once. Now, ma'am.
No, not yet. You can try the icon down or
Did you try sharing window? Or did you try sharing screen when you put the share screen thing?
Yes. Window is only there, ma'am. It's not the this thing. For me, it is coming in the slideshow only, ma'am. I am not understanding actually.
Okay, start. I think we can enlarge as you.
No.
I mean. Deepthi, you start. Deepthi, I don't think we should waste any more time. You can just enlarge it.
This is coming in not. I'll start, ma'am.
Yeah.
Okay. So good evening, everyone. Today we'll be discussing about the neuroradiological findings and little in detail about the congenital toxoplasmosis. Neuroradiological findings in the torch will be a brief discussion. So our objective mainly is to acknowledge the neurological findings of the torch infections, to elaborate the discussion on toxoplasma, and brief discussion on others, to understand the timing of intervention in
Deepthi,
ventricular
the slides are not moving. Sorry. Wait, let me try sharing it. Yeah. Is my screen visible?
Yes, ma'am.
You can
Yes.
stop.
Okay. Uh, so this is to acknowledge the neurological findings of the torch infection and a little detailed elaboration on the congenital toxoplasmosis to understand the timing of intervention in the ventriculomegaly. So So this is a case of a baby of Manjula. Baby was born on 19th of January 2023 at 6:35 p.m. It was a term gestation, 37 weeks. Birth weight was 2.7 kg. Baby was born by LSCS in view of the cephalopelvic disproportion. Antenatally, 12 years of married life, third degree consanguineous marriage, and there was an IVF conception. She was a primary mother. Medical, there were no antenatal problems, as well as the medical problems were not there in her. All her anomaly, as well as the Doppler scans, were normal. So this was an outborn baby. Baby had cried immediately after birth, was initiated the breastfeeding within the first 2 hours of the life. Baby was discharged on day 3 of life. Hospital stay was uneventful, except the baby was given a formula feed for first 2 days. But at the time of the discharge, baby was on direct breastfeeding. So from day 3 to day 19 of life, baby was having a normal weight gain, was passing urine, stools exclusively breastfed, as well as gaining weight. Um, okay. So this baby on day 20 of life. So baby was brought to St. John's emergency with the complaints of poor feeding and reduced activity since 1 day. But there was no other significant history, like history of decreased urine output or the jitteriness, seizures, fever, and there was no history of poor feeding or irritability in the past few days. Also, it was just 1 day history with the baby had come with. So on examination, vitals were like baby was euthermic, pulses were well felt, heart rate was between 120 to 130, 128 it was, and the respiratory rate, even rates were, tachypnea was there around 50 to 52, but respiratory efforts were not that great, and saturation was between 85 to 88% on the room air. Admission GRBS was 53 milligram per dl, and head to toe examination, baby's head circumference was 35 centimeters, which was normal. AF was widely open and bulging and pulsatile. Parieto-occipital sutures were separated. Other baby didn't have any dysmorphic features or any abdominal distension hypertension, no hyperpigmentation of the skin, no ambiguous genitalia, no abnormal movements, no signs of any external bleeding. So systemic examination, baby was in a supine semi-flex position. Baby was drowsy in the mental functions, and the pupils bilaterally equal and reactive. Cranial nerve examinations were normal. Tone, there was an hypotonia, and the DTRs were normal. So in the in the ma'am, I think it went into the normal one.
So, you're not able to see the PPT?
I'm able to see, ma'am. I think the slide share has gone.
I
I continue it, ma'am. So in the initially baby was stabilized with the like respiratory support was given. Baby was put on NIPT of mode of ventilation, but in view of poor respiratory effort, baby was intubated. Baby was on invasive mode of ventilation uh, from day 2 of admission, and chest X-ray was normal. Circulatory part, there was no features of shock. There was good urine output. Baby was started on measured feeds, and baby had one episode of seizures in the form of tachycardia and desaturations for around 60 seconds, and was loaded with phenobarbital. So as well as late onset sepsis was suspected here because baby had a history of poor feeding and irritability. Blood culture was sent, and baby was started on antibiotics. So here we come with the case of neonatal encephalopathy, where baby is having poor feeding, irritability, as well as baby had one episode of seizure in the hospital. So there'll be different causes of neonatal encephalopathy. So it can be because of the metabolic disorders, or it can be because of the genetics condition. Metabolic disorders can be like sulfite oxide deficiency, molybdenum cofactor deficiencies, paradoxin dependencies. Anything can cause the seizures, and genetics and epigenetics can also be the reason. Maternal risk factors is also one of the condition, but here as such we didn't have any significant history from the maternal risk factor point of view. And for the preconceptional risk factors were also not there. Placental pathology was not known. Hypoxia history was not there. Baby had cried immediately after birth, and there can be a perinatal infection, which again was not there from the history, but still it can be suspected. So our baseline investigation, so mainly we had kept from the differential diagnosis point of view. So it was taken metabolic risk factor as one of the important cause, and the perinatal infections, which can be just an sepsis because of any bacterial viral infections, or it can be something related to torch infections, as well as genetics. Epigenetics was something which we can't rule out at this stage. That was also kept in mind. So accordingly, basic investigations were done where CBC was normal. There was no leukocytosis or leukopenia, and there was no thrombocytopenia. The CRP was normal 0.3, and electrolytes were normal. And IEM workup was done, which didn't show any acidosis. Lactate, ammonia levels were normal. LFT was normal, and CSF showed a total count of 10 cells with the differential count neutrophil 1. Basically it was a lymphocyte predominance was there, as well as protein was elevated 1560, and glucose had shown hypoglycoria, that is it was 30. So here based on our differential diagnosis, so meningitis was first thing. So 4 point was there was a history of encephalopathy and seizures, but against point in this was again a CSF analysis as a sepsis screen were not favoring the diagnosis of meningitis. For the torch infections, again, encephalopathy, seizures, CSF was something which was important because here CSF cleared 16 cells, lymphocyte predominant, elevated protein, and hypoglycoria. Hypoglycoria is an important point for torch infection. So that was one thing which was favoring for the torch infections. But again, there were no other features like no prematurity, no IUGR, no hepatosplenomegaly in this baby. Metabolic disorders, the against points were no hypoglycemia, no metabolic acidosis, lactate levels were normal, ammonia was normal, and basic metabolic workup was normal. So this was the NSD which was done on the admission, which showed a dilated lateral as well as the third ventricles, and fourth ventricle was seemed normal here. Posterior fossa was normal, and there were no parenchymal or the intraventricular bleed and no midline shift. So this in the this based on the USD, so there was an like dilated lateral ventricles. Fourth ventricle was something which was not visualized, so we thought it is a like non-communicating hydrocephalus. This is a bedside NSD which was done. Next.
Yeah.
So as a causes of ventriculomegaly or ventricular dilatation, so we have many causes like cerebral atrophy can be one of the cause, but again there was no atrophy features. CSF flow obstruction, which can be because of the aqueductal stenosis or the posterior fossa malformations, and decrease in the CSF reabsorption that can again be because of the IVH, subarachnoid hemorrhage, intracranial infections. So based on this, it was mainly showing a feature of aqueduct, might be aqueductal stenosis, or it might be a case of a intracranial infection where there is a decreased CSF reabsorption. It can be developmental anomalies, but NSD didn't show anything chromosomal or genetic abnormality. We didn't have any other features in the baby. CSF overproduction, choroid plexus papilloma can one of the reason for hydrocephalus. So we had got based on our differential diagnosis of meningitis, torch infections, and metabolic, it was mainly looking like a torch infections. So suspicion of the torch infections, we had gotten ophthalmoscopic examination done, which showed a bilateral chorioretinitis. So torch panel was sent and toxoplasma was reactive. This is mothers and the babies both were sent. So mother, IgM, IgG both were reactive. In the baby, IgM, IgG both were reactive. And even the rubella IgG was reactive in the mother as well as in the baby. CMV, IgG was reactive in the baby. HSV1 was IgGs were positive. So with this, we had sent a CSF PCR for the toxoplasmosis and urine PCR for the CMV, and the CSF PCR for the toxoplasmosis came positive.
Deepthi, can you share your screen for showing the MRI?
Yes, ma'am.
You just put it in normal mode without putting into PowerPoint and enlarge it and show it.
Yes, ma'am. Yes.
I will stop share.
Yeah.
Sunita, you can please take over if whenever necessary, ma'am.
Sure. I mean, she's doing good. I'm here.
So this is the MRI. I have the video, but this is the pictures which we got from our MRI, which was showing the.
Enlarge it little bit more, Deepthi, like into some.
Yeah. Yes, ma'am. Yes, ma'am. Okay.
Yeah. Okay.
So this was showing MRI, which we got it, and it was showing the dilated lateral ventricles as well as the third ventricle and the fourth ventricle. So here there is a dilatation of both anterior horn as well as the occipital horns of the lateral ventricles were dilated, and This was the main feature, as well as there was a basal ganglion abnormality was the reporting from our MRI. Ma'am, anything you'd like to add, ma'am?
Yeah, so if you see at the level of the basal ganglia, there are
Yeah,
some kind of abnormal,
yeah,
hypointensities. So
yeah.
this baby was not cooperative. There was too much of motion artifacts. So we could not get a detailed image of this. But quite a number of time when we saw these abnormal signal changes at the level of the basal ganglia, when we saw them on SWI sequence, which is a associated sequence, it was all showing blooming. Like it was showing up. So only two things shows blooming. Like it shows up as a hypointensity on SWI. One is blood and one is calcification. So, because of the history, I told them it would be great because CT will not take a lot of time. The babies don't have to be cooperative and it will be over in a minute. So, and with the high clinical suspicion and these, suboptimal MRI images, I think we went ahead with the CT after this.
Yes. So,
Yeah, I will share the screen.
I will stop it, ma'am.
Yeah.
Yeah, basically what we saw was we saw hydrocephalus and calcifications in the corticomedullary junction and in the basal ganglia. So this was very much consistent with congenital toxoplasmosis. So this is one of the very rare cases where we get to see the imaging findings and appropriate diagnosis correlating with this. So uh, this was a worked up case of very good worked up case of congenital toxoplasmosis.
And this case particularly didn't have any antenatal scans had like showing such a, because this baby presented on day 20 of life and was having the such a dilated ventricles, but we didn't have any antenatal scans showing the dilated ventricles, which usually will be there in most of the cases.
True, true. And again, it depends upon what pathogen, what time it was contracted, everything else. Quite a number of time we see it or with hardly anything. So many times it may not, imaging factors may not be there also. If it is, subtle, it is a range. It ranges from mild to, a very obvious form like this.
Yes. So the treatment aspect of how we manage the case as a treatment aspect, one is the medical management and the surgical management. In the medical management, so for the congenital toxoplasmosis infection per se, pyrimethamine we started with the loading dose of 2 mg per kg per day for 2 days, and then 1 mg per kg per day for 6 months. So baby is on the pyrimethamine, and this will be continued with 1 mg per kg per day thrice weekly, with the sulfadiazine at 100 mg per kg per day in 2 divided doses, and leucovorin 5 to 10 mg 3 times per week. And we had to start the prednisolone also for this baby because of one is the protein levels were more than 1 gram per dl. It was 1500, as well as baby had an active chorioretinitis, retinitis, so baby was started on the prednisolone also. So treatment for this has to be continued for 1 year, and before starting, we have to rule out the G6PD deficiencies. And monitoring, we have hematological adverse effect occurs in 30% of the cases, and this antifolates and sulfonamides are known to cause a bone marrow suppression. So folinic acid supplementation was given along with the treatment, and CBC every 15 days for the first 2 months, followed by monthly once. Anytime neutrophil going less than 800, temporary cessation of the this medications has to be done. But all the studies have not shown any long-term hematological abnormalities with such a long use of these drugs, and very rarely Stevens-Johnson syndrome can be the side effect. Alternatively, azithromycin can be used, which has a good intracellular concentration, and macrolides, clindamycin, atovaquone can be used, but those are the best drugs. Pyrimethamine and sulfadiazine are the best drugs. So for the hydrocephalus per se, serial LP, serial ventricular tap, then the temporary device, that is the external ventricular devices, or the ventricle subgaleal shunts, and permanent surgical management can be done. So serial LP, it is effective in communicating hydrocephalus. In our MRI, it showed all the ventricles were dilated, so it is communicating hydrocephalus, and 10 to 10 ml per kg per day is drained. Rate of removal should not be faster than 1 ml per kg per minute, not shown to significantly affect the morbidity and the mortality, and also the risk of infection is higher with the serial LPs. So serial ventricular tap, repeated ventricular tap incur a new injury to the frontal lobe with each pass of needle. Again, this is a problem with the serial ventricular tap, which can cause puncture porencephaly. And each axis expose the child to the risk of infection and loculated hydrocephalus. So what are the index we use and to know this particular hydrocephalus has to be drained? One is the Levine's index, which we take between the absolute distance between the falx and the lateral wall of the anterior horn of this lateral ventricle. And if it is more than 97 plus 4 mm over the line, then above that graph, then it is shown that it is a time we have to like intervene and drain the CSF. One more index which is considered is the anterior horn width. Again, this is the width of the anterior horn of the lateral ventricles. So again, if it is more than 97th percentile, again, this is one of the indication for drainage. So this is the thalamo-occipital distance. So it is between the thalamus and the occipital horn of the lateral ventricle, and this is also again has to be checked. And if it is more than 97 centile, draining has to be. And this is a third ventricular width, which is if it is more than 3 mm or 1 mm plus 97 centile, it has to be drainage has to be done. So in our NICU, serial monitoring of all these indexes were done, and based on that, we had decided to treat the hydrocephalus. So. And one more is the temporary devices, which include the ventricular subgaleal shunt, where we are going to create a space between the ventricle as well as the subgaleal space in order to drain the CSF. So the average longevity of this, it's a temporary device of the primary VSGS was 35 days and 37 days. The survival duration of this VSGS, it depends. It depends upon the absorptive capacity of the subgaleal space, and we have to create ample space during the dissection. The effectiveness of this VSGS, it reduces the, like how do we assess the effectiveness is one is if there is an increasing head circumference, there is a reduction of head circumference, softening of the anterior fontanelle, as well as reduction of the ventricular size on neuroimaging. VSGS failure is indicated either the previously soft fluctuant subgaleal pocket becomes tense over the time and subgaleal space becomes obliterated without presence of the subgaleal fluid. So these indicates that VSGS is a failure. Here we have to go to the permanent device. So complications of this is the wound leakage, kinking, blockage, and VSGS related death during the intraoperative period because of the sudden decompression of this poorly myelinated neonatal brains under high pressure, and which will cause intracerebral hemorrhages, as well as obviously any invasive thing that is it can cause infection, as well as formation of a pseudomeningocele in the subgaleal space. So subgaleal encephaloceles, this subgaleal encephalocele per se can result in the seizures, abscess formations, and infarction and herniation of the brain parenchyma. Requirement of the CSF taps before a permanent VP shunt is placed when the CSF absorption from the subgaleal pocket is no longer adequate to control the hydrocephalus and severe. So when VSGS failure happens, then we'll have to go with the permanent ventriculoperitoneal shunt. And before doing that, obviously the culture has to be done, CSF analysis has to be done, and rule out the infection, then go ahead with the permanent VP. Permanent VP shunting is indicated when the ventricle continue to enlarge at the body weight exits and continue to enlarge, yes, we have to go to the permanent, but body weight has to be more than 2 kgs. CSF protein levels should be below at least 1.5 gram per dl. Then VP stent insertion can be done. And ETV offers an alternative to that is the third ventriculostomy, endoscopic third ventriculostomy. It is going to offer an alternative to the shunt in an obstructive hydrocephalus. If we can't place an obstructive hydrocephalus VP shunting, then ETV can be done. ETV, combined ETV and choroid plexus cauterization may be effective in a few conditions where there is excessive production of CSF, like in choroid plexus papilloma. So this is how in our analysis we had monitored the baby. This is 9th was the admission when anterior horn width, the VI, the thalamo-occipital distance, third ventricle, as well as the resistive index. So all were actually, if we calculate, all were above the cutoff level for the intervention. So serial LPs were done. 15 ml LP drainage was done on 9th, on 10th, as well as on 11th. As we can see, there is no much difference in the neuroimaging monitoring what was done. So it was decided to put a temporary device. So this was the ventricular subgale, EVD was tried. That is, we had tried with EVD for 10 days. But with that EVD also, there were not much difference. So after the 10 days, it was we had decided to put a VSGS. Right now, baby was discharged also on VSGS. And after the VSGS, the parameters had reduced. It was below the cutoff level. And baby's neurological, there was mild neurological improvement in the baby. So follow-up, this is one study where they have done a long-term impact of treated congenital toxoplasmosis on the quality of the life and the visual performance. So here, 1 or 2 treated patients were followed till 22.2 years. Outcome measures were the so what they basically measured was the quality of the life and the visual outcome. So for the visual outcome, it was found that 60, that is 58.8% had an ocular vision. In this 60, 13 out of 60 had a reduced visual function. Quality of the life was not much different from the general population. Basically the neurological pathology, reduced visual acuity, foveal location of the retinal lesion, squinting, all this contributes to the reduced visual function. But whatever they have found with the treatment, quality of the life was equal to the general population. So how we have to follow up this congenital toxoplasmosis case is, one is the ophthalmological follow-up has to be done. Fundus check by direct ophthalmoscopy every 3 months in the first year and every 6 months in the second year, every year thereafter. Neurological is, if they don't have any cerebral lesions, then no neurological sequelae is going to occur. If they have an isolated calcification, this also has shown in most cases normal development. But with the hydrocephalus, which was in our case, they had chances of development of cerebral palsy, seizures, as well as intellectual disability. Complete neurodevelopmental assessment has to be done at 1 year, as well as transfrontal USG for the calcifications, and ventricular dilatation has to be done till the resolution. So this is the outcome of hydrocephalus secondary to the congenital toxoplasmosis. Here, 65 participants were included in the study and were evaluated at 5 years of age based on the gross motor function classification as well as the IQ in relation to the time of diagnosis and intervention. So when was the patients were intervened and how were their quality of the life. So this particular study showed that delay shunt placement beyond 25 days after the diagnosis of hydrocephalus was associated with the greater cognitive impairment. So among those with the shunt placement within 25 days after the diagnosis, the mean GMFCS levels were 1.9. 5 out of the 17 of these were too disabled to participate in the formal cognitive testing after excluding 2 patients with visual difficulties. So mainly this GMFCS levels were better, and it was good if they had intervened before 25 days. This is what the gist of this article telling. In our case, it was actually the shunt was placed beyond 1 month, that is the VSGS, which was placed after 30 days. This article is showing if it is done before, little better for their intellectual development and gross motor development. So this is the usual finding in the congenital toxoplasmosis, where they're going to have this ventricles will be having hydrocephalus or the hydrancephaly. There is going to be the calcification in the basal ganglia, thalami. Basically, it is an extensive intracranial calcification which we can find in the toxoplasmosis. And there is going to be can be microcephaly, macrocephaly, porencephaly, white matter abnormalities, as well as aqueductal occlusion secondary to epididymitis. This is a fetal ultrasonography showing a ventricular dilatation with the ventricular wall thickening. This is just a few images I'll be showing, not particularly related to our baby, just in general how the neuroradiology is going to be. And this is a lateral ventricular dilatations and subependymal calcification, which can be seen in the toxoplasmosis. Next slide. This is. Cytomegalovirus again can present with main clinical features of jaundice, petechiae, hepatosplenomegaly, intrauterine growth restrictions, preterm birth, microcephaly, hydrancephaly. So these can be the findings. Yeah. So this is again in cytomegalovirus, particularly again this can present with the ventriculomegaly. Calcifications, there's going to be this periventricular calcification is important for the cytomegalovirus. Again, in cortex, it can be pachygyria, lesioncephaly, schizencephaly can be there, as well as cerebellar hypoplasia can be there in CMV. This is a cranial ultrasound, which is showing periventricular calcifications, as well as the small periventricular cyst in the white matter, parietal white matter. Arrow marks are showing. That is the in CMV. This is again all seen. That is cranial ultrasound, which is showing a periventricular calcification, as well as it is showing a symmetric cystic lesions. This is a T2 weightage MRI, which is showing a low signal adjacent to the lateral ventricles. This arrow mark is wrong. This is the adjacent lateral ventricles, as well as it is showing a calcification. Yes, that is one. Yeah, calcification of the and symmetrical part is calcification. The symmetrical occipital cyst is also there. It's down. Yes. So this first one is the image showing a cranial ultrasound parasagittal view, which is showing a periventricular cyst in the frontal white matter. And next one is a T2 weightage sequence, which is showing the same periventricular cyst. And this image is also showing a cerebellar hypoplasia. This is a T1 weighted image, which is showing arrow marks is showing that is bilateral cyst of the temporal horns. This is an inversion recovery sequence, which is a coronal sequence, which is showing the cerebellar hypoplasia and reduced gyrations. So this is a T2 weightage image, which is showing a ventricular dilatation along with the low signal intensities adjacent to the lateral ventricles. These are suggestive of calcification, and the cortex in the periselvian region, which is abnormally thick. This is again showing a polymicrogyria kind of picture. Next. Congenital rubella syndrome, 50% of the cases will present with the intrauterine growth restriction, along with almost same features of thrombocytopenia, petechiae, purpura, hemolytic anemia, hepatitis, jaundice, hepatosplenomegaly. Blueberry muffin spots is one thing which we can find in rubella on the head, neck, trunk, which represents an dermal extramedullary hematopoiesis. Then it can also have this myocarditis, long bone radiolucencies, interstitial pneumonia, meningoencephalitis with elevated CSF protein levels and pleocytosis. 3/4 of the infants again here develop the sensory neural hearing loss, and congenital heart disease occurs only when the fetus is infected during the first 8 weeks of gestation. So long-term outcome, almost 26% of children will be severely mentally retarded. 12%. This is again I've taken from an article which is showing a long-term, where the children were followed up to 6 years of life, where 26% of the children are severely mentally retarded. 12% had a neurological problem. 18% had a behavioral abnormalities, and 6% had developed autism. Congenital rubella can have ventriculomegaly, basal ganglial calcifications, as well as periventricular calcification, polymicrogyria, multifocal white matter hyperintensities, mainly in the frontal lobe, and corpus callosal agenesis and microphthalmia. So this is an cranial ultrasound which is showing a cystic foci in the bilateral caudothalamic grooves. And yeah, this is a fetal MRI, which is showing a bilateral temporal cyst and a subependymal cyst. And the same. First images are the fetal MRI, and next C and D are the postnatal, after birth. The MRIs has been taken, so they are also showing the temporal cyst as well as the subependymal cyst. This is showing that is the hyperintensity T2 image, which is showing hyperintensities of the white matter in bilateral cerebral hemispheres. Next one, it's almost same. Herpes simplex virus, it can cause growth restrictions, vesicles, scarring, neurological damage, it is intracranial calcifications, microcephaly, hypertonicity, and the eye involvement can be there with chorioretinitis and cataract. It can again, they are again going to present with the same presentation of ventriculomegaly, hydrancephaly. Calcifications are less common in the herpes simplex, with microcephaly, porencephaly, and corpus callosal agenesis can be present here also. This is the C and D mainly are the DWI or the ADC, that is diffusion weightage images, which is showing a restricted diffusion in the cortex regions, bilateral parietal region mainly. Yeah.
Temporal and parietal.
Temporal and parietal. This is one image which is showing this corpus callosal agenesis, which can be present in all this last three, which I mentioned, is rubella as well as herpes. This can have this corpusal agenesis features.
You want to project the last slide of summary?
Yeah. Yes, ma'am, I'll do that. So mainly, as we saw, actually all the torch infections can have the same features. They can present with the mixed features of all of them can have the hydrocephalus. They can present with the calcifications, hydrancephaly, or this microcephaly or lesioncephaly, all this, but particularly like cytomegalovirus will have more predominant periventricular calcifications, which has to be identified. And in toxoplasmosis, mainly we'll have a diffuse cerebral calcification and hydrocephalus, which was in our baby. And in rubella, there is going to be the same, all the features can overlap. Subcortical cyst will be mainly present in rubella. And And in herpes simplex, there is mainly the signal abnormalities of the temporal lobes, which is going to be present. Varicella mainly presents with the cerebellar hypoplasia. So there can be overlaps in our case. So basically, child presented at day 20 of life with the features of poor feeding. So initial our diagnoses were late onset sepsis, metabolic, and for the torch infections. And initially we had not thought of torch infections, mainly the infections, but based on NSG, when it was found there is hydrocephalus, we had got a torch profile along with the ophthalmological examination, so which showed a feature of torch like toxoplasmosis, having hydrocephalus and chorioretinitis, and intracranial calcifications. So it was managed medically, and then with the extraventricular drainage, serial ventricular tapping, and finally with the VSGS. Uh, the right now the baby is on follow up with us. Baby is developmentally, can't tell it is improved, but better. Baby was initially on tube feeding. Right now it's on palada feeding. But the only thing is baby has developed seizures, which is going into an uncontrollable seizures. So baby is on 3 anti-epileptic drugs. So yes, this will be the.
Thank you, Dr. Deepthi. I'll just project the CT of the baby for everybody to see once.
Yeah.
So is this visible?
This
Ma'am,
one.
Sunita,
Yeah,
ma'am?
yeah. So
Yeah.
yeah, I'm here. So this is a CT image. If you can see, this is the bone. The white color thing is the bone, which is very well highlighted. The cortex is so well highlighted in the CT. And so whatever the hyperdense things we see here in the basal ganglia are the calcifications. And we also have calcifications in the corticomedullary junctions of the cortex here, this one. So the discussion was all very extensive and good. So when we see this kind of picture, especially with hydrocephalus, the two important, these are the closing remarks. One thing we need to keep in mind is pseudotorch. As radiologists, when we don't have enough history and when we tend to see something like this, we may give a huge differential of other things like Aicardi Gutierrez, which also presents like bilateral basal ganglia calcification, which may actually not be, but serologically it may not show up with the torch. So similarly, Dandy-Walker malformations with this kind of hydrocephalus antenatally or postnatally with the ultrasound and the MRI brain. So Dandy-Walker malformation and these congenital syndromes like this Aicardi-Goutieres and cocaine syndrome. These are the two syndromes which we should always keep, that these could be not really torch. So it is called as pseudotorch spectrum. So these are the three things which we should keep in mind along with the torch when it comes to the radiological appearance.
Thank you, ma'am. I open the forum to any questions. You're welcome to put in the chat box or raise your hands. I think there is already one question. Did we inquire cat contact in the mother? Is the most sorry. Okay.
Yes, we had inquired for the cat exposure in all forms. There was no history of that.
The most common mode of acquisition of toxo in adults or mother is cat contact.
Yes.
The most common. So ideally, yes, cat contact is the most, but I think those spores can be it can be available anywhere through. It can be available through soil, contaminated vegetables, meat, etc. So anyone is at risk for this toxoplasmosis, but those in contact with cats definitely. CMV was negative in mother, positive for IgG in the baby. Not aware about this. Is this a possibility? Can you throw some light on this? Yeah. So baby was probably 20 days old. Probably it shows that baby did have some form of passive immunity to CMV. But again, the urinary CMV PCR, which is the most diagnostic test, was negative. So it didn't indicate any form of CMV infection in the baby.
And also the pattern of calcifications in
Yeah.
the CT, which is not periventricular, and we don't have any gyral abnormalities. So with imaging also, all the features favor toxome congenital.
Yes, ma'am. Any other questions? I don't see any raise of hands as well. What is the diagnostic test for congenital toxo? Dr. Deepthi, do you want to take that?
Actually, gold standard, yes, ma'am. Gold standard is this Sabine-Feldman test, which they tell, but it's like not every laboratory is going to do that. So for us, it will diagnostic. What we had considered is the CSF PCR, which we had done. So that is the final diagnostic test. If it is positive, yeah, that is taken.
Yeah, right. I also agree with you that PCR is the most confirmatory. Any other questions? Any geographical predilections in prevalence of toxo in India? I'm not aware of geographical predilections of toxo in India, but maybe we'll have to look up that to see if any studies are there. Rationale of doing torch in the mother, I think Deepthi, you can answer that.
Actually, there is okay. Actually, there is no indication. Whatever the articles I have reviewed through, there are no actual universal indication that mother has to go through the torch profile, because most of the times it is, if it is IgG positive also, there is very rare chances that uh, it is going to affect the baby. That is the reactivation of the toxoplasmosis infection and affecting the baby is a very rare thing. As well as, if yes, obviously IgM positive, it has to be concerned, but there is no universal criteria or this thing to do the torch profile for the mother.
Unless you have a fetus who has some stigmata, like for example ventriculomegaly, then in this baby, why did we do is that one was the presence of ventriculomegaly, second was the presence of high protein in the CSF, and like ma'am said, the typical picture in the MRI of calcification. So the other thing was to do
Was
in
also
the
the very leading characteristic feature, chorioretinitis. Yeah.
Yes, chorioretinitis, as rightly pointed out. And so that is why we had sent for a torch. In the baby, it came positive, so we did it for the mother as well to see whether it is perinatally acquired. Because this baby presented on day 20 of life. Prognosis of congenital toxoplasmosis. Yeah, I think Dr. Deepthi discussed that in detail during the slides, that it all depends upon what were the clinical features. I think the recording will be available for you to go through once again, and we would also share the slides. So I think that comes to the end of questions. If anybody wants any closing remarks, they can raise their hands. Otherwise, we can close this meeting. Okay. I don't see any show of hands or nor any more chats. Thank you one and all, especially thank you Sunita ma'am for your wonderful inputs, and also Sunita ma'am has been very helpful to us in actually helping us work up this baby as well. Thank you, Dr. Deepthi. Thank you, ma'am.
Always a collaborative effort, because
Thank
it's always a collaborative effort for the best diagnosis. Yeah, thank you. It was nice being a
Thank
part
you.
of.
thank
I
Thank you
would
very
like to thank Bharti ma'am and Sunita ma'am for this opportunity and helping me with all this slides and presentation. Thank you, ma'am. Thank you.
Yeah, thanks, Dr. Deepthi, for that
Thank you.
presentation.
Thank you.
Thank you all for joining. Good night.
Good night.
Mm.